So we'll have our next talk by Dr. Sushmita Kaushik. She'll be talking on application of newer glaucoma trials in our clinical practice.
Good morning, and at the outset, thank you for the opportunity to present this. So, newer glaucoma trials is something like landmark trials are something like an alphabet soup. And we have all of these which have been done for glaucoma. The research questions for most of these trials, surprisingly, was initially should we reduce the IOP? So, the ocular hypertensive treatment study, the CNTGS, the early manifest glaucoma trial, the AGIS, and the CIGTS actually answered the question as to should you reduce the IOP, and if so, in whom and in which stage. And I think we are done with that. So I'm not going to touch upon these because these trials are done and over with, and across the spectrum of glaucoma, we now understand lowering the intraocular pressure is beneficial. So the next set of the alphabet soup was how should we reduce the IOP? And then is the surgery, then which surgery? So which surgery was answered by TVT, the trap versus tube for already done surgical patients, and the primary TVT, which was done for patients who were treatment naive. If you wanted to put in a tube, which tube? So it was whether it's a bar welt or whether it's an AGV. If it was laser, is it good enough? Should we be doing SLT? So the light trial did that. Is cataract surgery beneficial for glaucoma? The Eagle study did that. And for the MIGS, the validated study that we have is the Hydrus 2, which we don't have in India, so we'll talk about that later. So, the outline in the next couple of minutes, we'll look at the second part, which is newer. Which surgery? The TVT or primary TVT. Which GDD? The Ahmed versus Barwelt or the Ahmed Barwelt comparison. So, there are two large trials comparing the two. For MIGS, there was the Hydrus 2, which had happened. Laser, the light trial has undergone a 5-year follow up recently, so we look at that. And whether or not cataract surgery should be done or early glaucoma surgery is beneficial was looked at by the Eagle. So let's do the TVT first. The trabeculectomy versus tube study. So this question was always there that somebody with failed glaucoma surgery or previous cataract surgery, should you do a trab or should you do a tube? This was a multicentric randomized controlled trial with uncontrolled glaucoma pressures between 18 to 40 millimeters on maximum tolerated medical therapy. And these patients were randomized to a trab with MMC or a Barwell glaucoma implant. The outcome measures were the intraocular pressures, the visual acuity, fields, and the surgical complications. So, which has better treatment outcome at 5 years? So, they did publish 1 year, 3 year, and 5 year data, but let's look at 5 years. So, the key findings of this study was the failure rate with TRAB with MMC was about 46%, and with the tube, it was about 29.8%. And the reoperations for glaucoma were more in the TRAB, 29%, and less in the tube, 9%. So, that sort of seemed to suggest that you're much better off doing a tube than reattempting a trab in somebody who's already failed a trab. The visual loss had similar rates in both groups, and early post-op complications, the trabs had much more than the tube shunt, but the late complications were similar. The lesson for the clinician is that the mitomycin used was 0.04% for 4 minutes. Now, that's a lot of MMC usually in the eye, and there's no procedure superior for treating a glaucoma, remember that. And the keep tubes in the armamentarium of surgical options and assess the patient's unique needs. But probably if you had reduced the time or the concentration of the MMC, those early complications of hypotony, etc., of the tubes might have not been there. And the factors for selecting a surgical procedure depends on the surgeon's skill and experience and the surgeon's planned surgical approach. So this was a very guarded outcome or conclusions of the 5 year data because they were a little guarded in saying that trabs were worse because the whole world didn't use these concentrations of trabeculectomy. So the next question was, okay, then what is the best procedure for a primary surgical approach? So multicentric trial compared the safety of tube and trab without previous ocular surgery. and 242 eyes, again randomized. And the major difference here, and these were the same authors, was that they used MMC 0.04 for 2 minutes. Now, that was what was more worldwide used. So they reduced that, and then let's see what happens. So the key findings, again, 5-year data. Tube shunt implantation and TRAB are both viable surgical options who in glaucoma patients who had no previous surgery. So both procedures reduced IOP to the low teens. Mean IOPs were actually significantly lower with the TRABs. So the primary TVT study told us that the TRAB resulted in a better IOP outcome if there was no prior ocular surgery, and early complications, which they said was after TRAB, but they were all self-limited, and serious complications producing vision loss were more frequently seen with the TRABs, but it wasn't statistically significant. Now, failure rates, reoperations were more in the tube, 37 versus 24%, and hypotony was more than in the TRAB, as expected, 10% versus 0, because you're ligating the Barwell. So the overall success rate was same, and complete success rate was actually significantly higher in the TRABs. So the factors for failure were a higher pre-op IOP and a lower pre-op IOP for more tubes. So if we chose a tube, now that's the next question, which one? So finally, if you've decided, okay, I'm going to do a tube in this patient. So there were two large clinical trials, the ABC, Ahmed-Barwell comparison, and the AVB, the Ahmed versus Barwell. So rather than go into that, there's a lovely publication of pooled data analysis from both these studies. So I'll just present that. 5 years later, these were the results. The Barwell implant had a low failure rate, a lower rate of glaucoma resurgery, better intraocular pressure, lesser medication, and a higher rate of hypotony. So that was a little bit of a caveat, but by and large, now this sort of stamped the fact that a non-valve device ultimately seemed to do better than the valve device. So the next is the LIGHT study. This is the laser in glaucoma and ocular hypertension. And this again was a multicentric RCT with 6 participating centers, which looked at newly diagnosed, non-treated POAG or ocular hypertension, and decision to treat was made by the consultant ophthalmologist. So that was allowed. The research question is, which is better as a first management? Is it SLT or medication? So the lessons were there's no significant difference in the health-related quality of life, but 74% of patients in SLT remained drop-free. And there was a lower cost, incremental, because you didn't have to buy medications after the initial costing. And SLT seemed to provide better diurnal in IOP stability with a continuous effect on the trabecular meshwork versus the episodic administration of medication. The next most controversial study, if I may say, is the effectiveness of angle closure glaucoma of lens extraction, the EAGLE study. The two major goals were in primary angle closure and high IOP or PACG with no cataract. Is early lens extraction or laser iridotomy and medical care a better treatment choice? And is lens extraction or standard of care more cost effective in the medium term? So what was reported was 419 participants randomized, 208 had clear lens extraction and the others had standard care. 84% had complete data and 87% had IOP data. Now the IOP data was, it was 1.18 millimeters lower after clear lens extraction. And of course, it was more cost effective, which was irreversible loss of vision with 1 participant in clear lens extraction and in 3 who received standard of care. The points to ponder for us when we read this is there's missing information. So I would like to know what was the gonioscopy. There's missing in 247 of the 419 eyes. I don't even know what has happened. Has the angle opened up? Was there synechial closure? What was the problem? There's no information, and these are likely to be the ones presenting with glaucoma. PSC more than 30 millimeters of mercury is likely to be an appositional closure with a thick lens. There's no information on lens thickness. Maybe the lens vault was high enough to warrant a PAC, which means no glaucoma with 30 millimeters of mercury. Now, that's not a usual scenario in the clinical setting. And in these cases of standard of care could have been lens extraction anyway. So if you have a large lens vault and the disc is normal and the pressures are 30, probably it's reasonable to think of taking out that big lens in a small eye rather than doing anything else. And very early glaucoma, again, is not real world data. The strengths of this study, which is what they said in the complications, IOP lower. 1.1 millimeters at 3 years. How relevant is that clinically? Even though your stats say it's significant, how relevant is a 1.1 millimeters of mercury difference? Better quality of life? Of course, that's likely to be because of the intraocular lens. But your age is more than 50. So you're likely to have a nuclear sclerosis anyway. So are you just taking out a lenticular myopia? Is it more cost effective? It's only in a UK setting at the NHS where it's free. Is it cost effective because the surgery is free, or would it be cost effective across the board? I'm not sure we would translate into all that. So in a nutshell, remember, can I take 30 seconds more? Yeah. Okay. So, in a nutshell, remember quality of life. They're non-Chinese. They favor standard of care. Chinese probably have smaller eyes and a larger lens thickness. So, a non-Chinese quality of life favors standard of care. It's only the Chinese guys who had a better quality of life. If you had PAC, again, it favors standard of care. It's only PACG which favors lens extraction. And if it's unilateral, again, it favors standard of care. So it's not across the board. Intraocular pressure overall, though it favors the clear lens extraction, but in the non-Chinese, again, the favor was in terms of standard of care. So if you go into this, there are a lot of ifs and buts in this paper. MIGS is here to stay. Since it's not so common, I'll just say there's one ISTEN study group which has published 2 years data. 50% of patients with phaco alone versus 61% of patients in the combined group had a IOP lowering, which was the target. Complications, of course, with the phaco was corneal edema, anterior chamber inflammation, and macular edema, and a 3% rate of stent malpositioning and a 1% rate of stent removal. So this was the ISTEN study group, but these are just 1 or 2 year data, and longer terms are here. I'm not going into hydrus because it's not available here as yet. When it comes, we'll probably look at it. To summarize, all trials have stringent inclusion criteria and defined outcomes. I don't know how much we can translate all these patients into the patients that we see. Statistical significance may not be clinically relevant, and the information provided by landmark trials needs to be used judiciously depending upon the needs and safety of the patient in front of you. Thank you.